Medurstand. Understanding medicine.
I am Professor Aziz-ur-Rehman, and today I'm going to talk about the role of SGLT2 inhibitors, particularly empagliflozin, in the glycemic control of diabetes. Now, two things I think need emphasis. Number one, SGLT2 inhibitors is a new class of drugs. It is primarily developed to control diabetes, but it has been found to have some very remarkable features which are beyond glycemic control. And I will have a separate lecture on those features, but here I will be basically focusing on glycemic control. And number two, of course, whatever I say will be applicable on all SGLT2 inhibitors. My particular emphasis would be on empagliflozin. Now, this is the agenda. The objectives of this talk is to cover number one, diabetes statistics very briefly, then brief review of kidney's role in glucose homeostasis, because unless we understand this, we will not be able to understand the exact mechanism of this drug, and empagliflozin mechanism of action, empagliflozin efficacy studies, empagliflozin safety study. So that will be the main contents of my talk, but very briefly I would mention about EMPA-REG outcome trials, EMPA-REG renal trials, EMPA-REDUCE trial, which make this drug a very unique drug. Then finally I will present conclusions. Now, diabetes statistics, according to IDF Atlas 2019. Before that, Pakistan was at number 8. Unfortunately, because of increased prevalence of diabetes, we rose to number 4, and we were projected to reach position number 3 in 2045. But very unfortunately, we have already reached that mark, and we are number 3 position as per total population with the diabetes is concerned. So that indicates the magnitude of problem and what we need to do. This is the world map showing various parts of the world, showing the prevalence and as marked by these color codes. But I will be focusing on this one. This place is called MENA region. This is Middle East and North Africa, where we live. Now, the maximum rise in diabetes prevalence is expected in Africa from 2019 to 2045. 143% increase is expected. And the second one is Middle East, and here we are expecting 96% increase in the prevalence of diabetes because of our changing lifestyle, unhealthy habits, and poor physical activity, and also some genetic factors. Now, if you compare it with the Europe, there is only 15% increase expected by 2045. So maybe we can also do something to reduce such a high increase in the prevalence of diabetes as some other countries have done. Now, first of all, brief review of kidney's role in glucose homeostasis. This is body, and first role, the most important role of kidney is the reabsorption of glucose. Very large amount of glucose is filtered through glomeruli, approximately 180 grams of glucose, which is absorbed almost completely. That is extremely important because glucose is our nutrition. Nature has provided us with this mechanism of reabsorption. If this mechanism was not there, then maybe after 3 or 4 hours after eating, we would be hypoglycemic and there would be brain death. And then utilization, of course, kidney is a functioning organ. It requires fuel and it uses glucose for its energy needs. And then it also produces glucose, like gluconeogenesis. The main organ which we know for gluconeogenesis is the liver, but second in number is kidney. Kidney also produces significant amount of glucose every day. Now, glucose in diet is approximately 180 grams per day, and approximately 70 grams of glucose is produced within the body by liver and by kidney. 80% by the liver and 20% by the kidney. So total 250 grams of glucose is daily metabolized. Now, kidney filters all the glucose. Whatever total glucose passes through the nephron, it passes through the nephron, and kidney it reabsorbs it for conservation of energy. It also utilizes 25 to 30 grams per day, and it produces 15 to 55 grams. So I think net is about balance. The basic function of the kidney, as far as glucose homeostasis is concerned, is to reabsorb, but of course these two are also important. This also explains why people with CKD, they tend to develop hypoglycemia so frequently. This is because this gluconeogenesis mechanism is not there when the kidneys are damaged. Now, out of this 250 grams, half of this is consumed by the brain, because brain is an organ which works very all the time, and it can consume only glucose as fuel, and rest of the body consumes remaining 125 grams of glucose. So this is an outline of the kidney's role in glucose homeostasis. Now, how does it reabsorb? This is renal tubules. Now you can see that this is the tubular lumen. This is, sorry, the cell. This is the lumen of the renal tubule, and this is the cell, and this is the blood. Now these proteins SGLT2 and SGLT1 are present here. SGLT1 low capacity, high affinity receptors are present in the intestine, which is primarily meant for the absorption of glucose from the food. SGLT2 inhibitors, SGLT2 receptors, high capacity and low affinity, are mostly in the kidneys. We also have some SGLT1 here, but mostly in the kidney we have SGLT2, and the basic function of SGLT2 is to absorb glucose from the tubular lumen into the cell, and then to pass it on to the blood. SGLT2 inhibitors, let's examine the mechanism of action. This is the nephron. A large amount of glucose is filtered into the glomerulus. It passes through the nephron, proximal convoluted tubules, and then the distal tubule, and then the loop of Henle, collecting ducts, and then finally into the urine. So this, almost all of it, 90% plus 10% makes 100%. So 100% of glucose is reabsorbed by SGLT2 and SGLT1 on the proximal tubule, so that there is no glycosuria. In a normal person, unless that person has low renal threshold, that is a condition called renal glycosuria, mostly normal healthy people should not pass any glucose in the urine. But if somebody is diabetic, he must be filtering much more than 180 grams, so some glucose is passing, because SGLT2, despite its maximum effort, it cannot reabsorb all the glucose filtered, so some glucose will be passed into the urine. So that means that will result in glycosuria. You all know that even mild to moderate hyperglycemia does not cause glycosuria. You need to have persistent hyperglycemia more than 180 to have glucose passing into the urine. So although in diabetes the total amount of glucose reabsorbed is much more than in a normal healthy person, because the total glucose filtered into the nephron is much increased, but still some glucose will pass into the urine. Now this is a person with diabetes. Now let's examine what will happen if we give SGLT2 inhibitors. So this is SGLT2 inhibitors. What it will do is that it will stop SGLT2 from glucose absorption. So all the glucose, in fact not all, a very large amount of glucose, like 80 gram plus amount of glucose, will be sort of forced to pass into the urine. Now this is a kind of unphysiological thing. In a normal physiology, kidney tries to preserve every single molecule of glucose, but here we are trying to to remove some glucose from the system. So SGLT2 inhibitors, they reduce glucose reabsorption in the proximal tubules, leading to urinary glucose excretion and osmotic diuresis. So this is the objective. Now one might think that this abnormal excretion of glucose into the renal tubules may be harmful, but actually it is not. It is actually beneficial. So what is the net effect of this? We are going to examine here expected clinical effects of SGLT2 inhibition. Number one, it is going to increase glucose excretion, and that will translate into reduced glycemia. So that is the primary objective of SGLT2 inhibitors. We try to prevent hyperglycemia. We try to bring it down to normal and without the risk of hypoglycemia. And it will result in like modest HbA1c reduction. In the studies, if we use empagliflozin or some other gliflozin with a therapeutic dose, we expect 0.6 to 1% reduction in HbA1c. So it has got modest glucose lowering effect. It's moderate, not very important. And the second effect of SGLT2 inhibitors would be loss of calories because of increased glucose excretion. Of course, glucose has calories. Since we lose calories in the urine, so we expect some weight loss. And according to various studies, one can expect 2 to 3 kilograms of body weight loss in 1 year with SGLT2 inhibitors. So these two effects can be attributed to glucose excretion. Then, because it will also increase sodium excretion. This is SGLT2. SGLT2 means sodium glucose co-transporter. So whenever glucose is prevented from being absorbed, sodium will also be prevented from being absorbed, and glucose will be excreted. Sodium will also be excreted into the urine. So that will result in some natriuresis. So there will be reduced sodium load in the body, and that will have the effect on blood pressure. So studies have shown there could be 3 to 5 millimeter of mercury reduction in mean blood pressure in those patients who are taking SGLT2 inhibitors. Now, if this patient is hypertensive, that patient would probably need another antihypertensive also, but SGLT2 inhibitors would also contribute to this extent in lowering blood pressure. And some of the cardiovascular benefits of SGLT2 inhibitors are actually attributed to this blood pressure lowering effect. And this net diuresis occurs without potassium loss. If we compare SGLT2 inhibitors with other diuretics like tube diuretics, they result in sodium loss as well as potassium loss, and potassium loss is not good. So in SGLT2 inhibitors, we lose sodium and we have some diuresis without any loss of potassium. So these are the expected clinical effects of SGLT2 inhibition. The pleiotropic effect of SGLT2 inhibitors, gliflozin, beyond the glycemic benefits. Those of you who do not understand this word pleiotropic, this means that a drug may be intended to have a certain effect, but sometimes we observe that it has got additional effects also. So those additional effects, which are usually class effects, they are called pleiotropic effects. So when it comes to SGLT2 inhibitors, there is a long list of such effects: natriuresis, BP lowering effect, and cardiac load lowering effect, and diuresis, sparing potassium. Then it also reduces oxidative stress. You know, oxidation of tissues may be harmful, may be damaging. It reduces oxidative stress on the tissues, on the endothelium, and also the tubular cells. And it reduces inflammation. That is also a beneficial effect. And then we have shift of metabolism from glucose to fatty acids. Our heart muscles, they prefer to use fatty acids as a fuel, but when we use it also uses glucose. In the presence of SGLT2 inhibitors, the metabolism is shifted from glucose to fatty acids. That somehow makes this fuel more efficient, and even if there is some ischemic heart disease, this has got some protective role. All these things, they explain these extra effect of these drugs, the beyond glycemic control. It is also believed to reduce glucotoxicity on cardiac muscles. So many good effects which are attributed to SGLT2 inhibitors. Now let's examine empagliflozin in clinical trials. First, of course, the efficacy, how effective this drug is. Now this is a summary of several studies, and now you can see this is the pooled data, and this is the people who were on monotherapy, just empagliflozin. These are the people who were on metformin and empagliflozin was added, and these are the people who were on pioglitazone, empagliflozin was added, of course, versus placebo, and then metformin and sulfonylurea, and people on insulin for at least 78 weeks, then people with mild renal impairment. So you can see various classes, various groups of people, various spectrum of diseases, and in all of them, if we use empagliflozin 10 milligram, this pink purple bars, or empagliflozin 25 milligram, this blue bar, there is significant reduction in HbA1c up to about slightly less than 1%, in some cases more than 1%. And of course, you can see the blue bars are deeper than the pink because this is 25 milligram of empagliflozin. And please also note that 25 milligram, although is more than double 10 milligram, but the effect is only moderately more than 10 milligram. So you can have most of the effect with just 10 milligram, but of course you will have some additional effect with 25 milligram empagliflozin. So this is the efficacy used in various setups as monotherapy or in combination of various other drugs. Now, since SGLT2 inhibitors, they have unique mechanism of action, this mechanism of action is not shared with any other class, so this effect is added to whatever other agent patient may be using. So this is a very unique feature of this class of drug. Now let's examine the effect of SGLT2 inhibitors on body weight across different background therapy and empagliflozin versus placebo. Again, similar pattern in pooled data, people with renal impairment and various groups, people on various drugs, empagliflozin versus placebo in 10 milligram and 25 milligram. You can see significant 2 to 3 kg body weight loss in all these patients. So that is additional effect. Then the effect on systolic blood pressure across different background therapy, empagliflozin versus placebo, all same groups, 10 milligram versus 25 milligram, you can see significant 2 to 3, in some cases 4 millimeter mercury reduction in systolic blood pressure. So this is the expected effect of empagliflozin. Now we are going to examine empagliflozin safety profile. In the last 3-4 slides, we have seen that empagliflozin is effective in lowering glucose when it comes to HbA1c measurement, approximately 1% reduction. It also lowers blood pressure. It also reduces body weight. Now we're going to study empagliflozin safety profile. First of all, hypoglycemic effect. I think any therapy, any blood glucose lowering therapy has to be judged two ways. One, its potential of causing hypoglycemia. The other, its potential of causing weight gain. Now let's see its potential of causing hypoglycemia. Now this part is very interesting. This is placebo, and this is 10 milligram empagliflozin. This is 25 milligram empagliflozin. You don't see any difference in the height of these bars. So placebo and 10 milligram and empagliflozin are equivalent when it comes to the possibility of hypoglycemia. So in other words, empagliflozin when used as monotherapy does not cause hypoglycemia at all. But when it is added to other drugs, now this is the part, people who were taking metformin and sulfonylureas, or other people who are taking multiple drugs, in them when you add empagliflozin, the incidence of hypoglycemia increases. As compared to placebo, 10 milligram and 25 milligram causes more hypoglycemia. Now this may be a little tricky to understand. Although this started happening after the addition of empagliflozin, but this hypoglycemia was basically caused by the baseline therapy, particularly sulfonylurea. So if somebody uses sulfonylurea, and even if patient is not on goal, and when you add empagliflozin or some other SGLT2 inhibitor, you may expect some hypoglycemic episode. So I think in advance you should reduce the dose of SGLT2 inhibitor when you add empagliflozin or some SGLT2 inhibitor. Now, events consistent with UTI stratified by gender. So, one of the known side effects of SGLT2 inhibitor is urinary tract infection. The reason is that because glucose goes into the urine, so the genitalia may be contaminated with some glucose that might actually attract some bacteria, and that may increase incidence of urinary tract infection. So when we take all patients with all events, there is no much difference. And when we see female patient, there is some increase in urinary tract infection with 10 milligram and 25 milligram. And in male patient, there is no increase in incidence. In fact, if you just see the height of these graphs, the incidence of urinary tract infection in men on empagliflozin may be less as compared to placebo. Of course, this is statistically insignificant finding, but at least it is not increased. So this is very reassuring. But when we examine male versus female patient, there is some effect in the female. In the next study, this is without history of chronic recurrent UTI. So particularly those women who have history of chronic UTI, recurrent UTI, it may be particularly relevant those patients. So if somebody gives history of frequent urinary tract infection, that may be considered, and especially if that patient is a woman, that may be considered a relative contraindication for for SGLT2 inhibitors. But in all other patients, the effect is so negligible that should not stop you from prescribing this class of drug. Consistent with UTI distribution event study, and this is, I think, yes, mild infection. Now, most of the patients who were on SGLT2 inhibitors or on placebo, their infection was classified as mild infection. So mild urinary tract infection is very easy to treat. So this should not deter you from prescribing this drug. And severe infection was not increased in patient on SGLT2 inhibitors. So I think this is very, very reassuring. Now then we study the genital infection distribution. This we have already done. This slide summarizes the main characteristics of empagliflozin. Everything in this world has the upper side and the downside. The upside is very strong, moderate A1C lowering effect without the risk of hypoglycemia and without any weight gain, in fact some weight loss. It is mostly convenient once a day, can be given twice a day, especially when combined with metformin, but as monotherapy it is given usually as once a day. It pairs perfectly with metformin. Metformin being first line agent, so empagliflozin very comfortably, perfectly pairs with metformin. So combination therapy is the second line. I mean, after metformin, you could give combination of empagliflozin and metformin. And very favorable cardiovascular and renal effect, which I'm going to examine in detail in my next video. And the downside is the polyuria effect. In some cases, it may be quite significant. In others, it may be mild. And then DKA, studies have shown that in some patients, it could precipitate DKA. So we have to be very vigilant, and it could be euglycemic DKA. So I think we have to be very, very vigilant. And then renal shutdown, very rare complication, and it is contraindicated if GFR is less than 30. So even if we know it is renoprotective, if GFR is less than 30, drug is currently contraindicated, and it should be discontinued in perioperative phase. So this is, I think, on the balance, the upper side is much stronger. Glucose lowering effect of SGLT2 inhibitors is independent of insulin. So it has got direct action independent of beta cell, and this is important because with time in all patients with type 2 diabetes, beta cell function is lost, it deteriorates. So that is why this effect is maintained even when the beta cells are significantly damaged. It is independent of insulin resistance. The results are that there is limited loss of potency because the effect is independent of beta cells. Effect is added when combined to any other anti-diabetic agent. This because it has got unique mechanism of action which is not shared with any other drug. Now after 2008, FDA issued a directive that all new drugs must have cardiovascular safety data, and this was after the rosiglitazone experience. So all these SGLT2 inhibitors, empagliflozin, dapagliflozin, and canagliflozin, all have these trials, which I'm going to discuss in detail in my next lecture. But they have all these drugs, they have passed this test, and they are now available for not only control of diabetes and also for their additional benefits. Now this is because of these trials, this relatively new drug has jumped to position number 2 after metformin. It is now considered to be one of the options in at level 2. Now let's examine the role of SGLT2 inhibitors according to American Diabetes Association guidelines issued in 2021. Now this is a very busy slide, and I will not go into the detail because this would require a separate lecture. Now this is the document, Management of Hyperglycemia in Type 2 Diabetes, a consensus report by the ADA and the EASD, two major societies in the world which regulate diabetes guidelines. Now this was published in two journals, Diabetologia and Diabetes Care. Because this was consensus statement of ADA, it was published in Diabetes Care and also the ESD's journal Diabetologia. So that makes it a very robust document, and this is available free online if you want to study. And these are some limitations of guideline, but I'm not going to go into details. Now this is the very simplified version of ADA and ESD guidelines. We start with lifestyle changes and metformin, and these are to be continued till end. Other medicines, other agents will be added and they will go away also, but lifestyle changes and metformin, they remain the first line treatment, the main treatment, and they continue. Now, after lifestyle changes and metformin, we have to consider other therapies. Now, although in 80% of the patients, those patients who have average risk of cardiovascular disease and renal failure, just normal people with diabetes, in them you could use any of the 5-6 agents available. But I think weight loss and hypoglycemia should always be the concern. So ADA has recommended that if you must prevent weight loss and you must prevent hypoglycemia, you should use those agents which are known not to cause weight gain and not to cause hypoglycemia, particularly SGLT2 inhibitors and GLP-1 receptor agonists. But those patients who are at risk of heart failure, or those who have heart failure, and those patients who are at risk of CKD, or those who have CKD, in them SGLT2 inhibitors should be preferred agent after metformin. And they recommend that you do not have to wait for metformin to fail. You don't have to irrespective of baseline HbA1c, after metformin, anytime you could use SGLT2 inhibitors. In fact, you could use these agents with metformin, and in fact, in some people, you could actually start with SGLT2 inhibitors if patient has heart failure or CKD risk. And those who have increased risk of atherosclerotic cardiovascular disease or renal failure, in them a GLP-1 receptor agonist. So I think I'm going to just hurriedly go through this. Those and these can be combined than other agents. So our focus is the SGLT2 inhibitors. Now, when we want to combine empagliflozin or other SGLT2 inhibitors, they have no compatibility issue with any other known anti-diabetic agent. They can combine very well with metformin or other drugs. Now, since empagliflozin and metformin, they make a very good pair, why not try them in combination in newly diagnosed type 2 diabetic patients? This was study and it was published, and there was very good results, and it resulted in powerful HbA1c reduction of 2.1% when combined these two drugs. So I think in some patients you could actually start, those patients who present with high A1c like 9% or more, one could start with combination of metformin and SGLT2 inhibitors, particularly if the person is overweight. Now, these are the studies which, of course, is beyond the scope of this lecture. This is regarding empagliflozin, this is regarding dapagliflozin, and this is regarding canagliflozin. This I'm going to cover in detail in my next lecture. Now, the conclusion, first of all, empagliflozin is a unique anti-diabetic agent, and it offers glycemic benefits without the risk of hypoglycemia, and weight benefits every 2 to 3 kg weight loss, blood pressure benefits about 3 to 4 millimeter reduction in systolic blood pressure, cardiovascular benefits, and renal benefits, and preferred second line agent in individuals with heart failure or CKD or increased risk of these two conditions. And then it pairs perfectly with all other anti-diabetic agents. It could be combined with insulin, with other agents. So I think that is because it has got a unique mechanism of action. Then acceptable risk profile, slight increase in the incidence of urinary tract infection and mycotic infection. So if I summarize by saying that this is the 4 pillars of diabetes management issued by ADA, and if we examine SGLT2 inhibitors, they address this issue, glycemic management. They have good favorable effect on blood glucose and blood pressure, and they do not have any effect here, but they are compatible with other drugs, and they have proven cardiovascular and kidney safety. So I think that makes this drug one of the very preferable agent. So this was Professor Aziz-ur-Rehman from Medurstand. I thank you for watching this video, and I really look forward to see you in my next one, which is going to address the effect of SGLT2 inhibitors beyond glycemic control, particularly the role in preventing renal failure, preventing progression of renal disease, preventing heart failure, preventing hospitalization for heart failure, preventing death related to heart failure and all-cause mortality. Till then, thank you very much. Look after yourself and see you in my next video.